should know what these two words mean. So angina and pectoris, right? Two words. Angina is pain. Pectoris is the chest muscle, the pectoral muscle, the chest muscle. So pectoral is chest, angina is pain. So this is chest pain, okay? And this is characterized by paroxysmal and usually recurrent attacks of substernal or precordial chest discomfort. And this is very transient. You see, the definition says 15 seconds to 15 minutes. And this is just myocardial ischemia, but not necrosis. So this concept is very important. A lot of you I know get confused with this concept of like this is chest pain and we are looking at a patient with chest pain and EKG changes, but this is reversible. Okay, this is not myocardial necrosis. This is simply ischemia. Does ischemia lead to necrosis? Answer is yes. Ischemia does lead to necrosis, but angina is not that situation where ischemia has led to necrosis. This is just, you know, myocardial ischemia, which is not sufficient yet to induce that cell death. Necrosis is permanent death, cell death, right? Okay, that is an irreversible sort of condition. Myocardial ischemia in this angina is sort of a reversible sort of stage. Okay, and the pain is a consequence of ischemia because of all these chemicals. Okay, like bradykinin. Okay, some sympathetic stimulation, vagal afferent nerve. All of these have been stimulated because of ischemia, and that is what is cause of this patient's chest pain. Okay, comparing three types of angina is important. So, what are the three things that you need to know? What are the three types or subtypes of this chest pain? Stable, unstable, and variant. Variant is also called as vasospastic, also called as Prinzmetal. Okay, so let's talk about all of these three. And I've drawn a table for you so that it's easier for you to differentiate and learn this. Okay, so let's talk about stable angina. Okay, so we have stable, remember, stable, unstable, and variant. Okay, or vasospastic. If you call it vasospastic, it helps you learn an important sort of fact about that, and I will just talk about that in a minute. So stable angina. Okay, let's start with this. So this is because of coronary artery narrowing to more than 70%. So arteries are narrowed down more than 70%. Okay, I want you to imagine this. Okay, because of atherosclerosis. Okay, so it could be you say 75%, like in our patient in the question that we just saw. So 75% occlusion or 70-80% because of a fixed stenosis, a fixed narrowing. It has not ruptured, it has not thrombosed, there is nothing going on, it is just the artery is narrow. Okay, so just learn in stable angina, it is a stable plaque. Do you remember in blood vessels chapter, we talked about stable versus a vulnerable plaque? So vulnerable plaque is vulnerable to rupture. It has ruptured probably, okay, that is vulnerable, okay, leading to acute coronary syndromes. You remember that, right? But stable angina is related to a stable plaque. Like, why am I stressing so much here? Because this has been asked as a fact, a question in so many exams, and we still keep confusing this. So stable angina, what is the cause? A stable plaque. It has not ruptured. It has just been there since like 5 years, many years. It's been there, right? Okay. So atherosclerosis. And what will the patient come to you with? Remember what the question that you saw? Exertional chest pain. Exertional chest pain. What is this word exertional? Patient will, how will the patient talk to you about this exertional chest pain? What will the patient come and say? The patient will say, I have chest pain when I walk. Okay, maybe like walk half a mile, or I go on evening walks, or 2 flights of stairs, or something like that. So exertional chest pain on exertion, right? On some physical activity. And this resolves with rest or nitroglycerin. So that is going to be given to you in the clinical history or the question. Okay. So treatment, of course, has rest and nitroglycerin here. Okay. Because it improves blood flow. So anything that improves blood flow to that region of the heart where there is narrowed blood vessel, less blood is going in there. So if you improve the blood flow, the situation improves, the pain disappears. Okay. All good. Unstable angina. Let's talk about vasospastic first, and then I go into unstable. So vasospastic is the variant, or also called as Prinzmetal. This is because of coronary artery vasospasm. Again, the concept of chest pain remains the same. There is less blood going into the heart muscle, right? That is causing the pain. And all these three you've understood now are different causes where less blood is going to the heart muscle, right? In vasospastic, what is that reason for less blood going into that heart muscle? Coronary arteries have undergone a spasm. Okay, they just constricted temporarily. Remember this, not permanently, temporarily. But that temporary vasospasm or constriction of this artery, did that cut off the blood flow? Did that create some ischemic situation? Yes. So this is a transient ischemia with positive ST changes. When I say positive ST changes, so ST might be elevated here. Okay. So this is another confusion area. We are talking about angina, not MI. ST can be elevated in angina. So you should know this very carefully. And there are 5 or 6 differentials I can talk about later. What leads to ST elevation? So it's not only the STMI. Okay, everyone knows about STMI, and if the question says STMI and ST elevation is there, and like you jump to a conclusion that of course this is ST elevation, MI. Okay, because of that connection in your head. Okay, but you should know, when does ST go up? ST is elevated anytime there is, for example, ischemia happening to the entire full thickness of heart muscle. Okay, learn this concept. Full thickness ischemia can also lead to ST elevation. So I think it's easier to learn and say anything that is affecting full thickness of the heart muscle or entire thickness of the heart muscle is affected, ST is going to be elevated. So in this case, what is happening to the entire muscle layer, the full thickness? What is happening? Ischemia. In MI, so there is a specific form of MI, which is transmural MI. Okay, we'll just look at it in the next slide, where infarction or necrosis happens all through the muscle layer, right? That also leads to ST elevation. Okay, so there are a few other things like pericarditis and inflammation that can also elevate the ST. We'll talk about that. Unstable angina, very interesting, and they do ask you this question repeatedly again. Unstable angina, what is the very interesting, important thing that you need to know, and they keep asking you question on? So basically what has happened is, like I said, stable angina was a stable plaque. What if a stable plaque became vulnerable? We did talk about this in our blood vessels chapter. A stable plaque can become unstable, and that is another MCQ they keep asking you. How does stable become unstable? Because of inflammation. You remember the enzyme question they ask you, because of rising levels of MMPs, a lot of inflammatory cells. Okay, MMPs are matrix metalloproteinases, where they sort of convert that fibrotic sort of cap in the stable plaque to, an unstable one. The cap of the atherosclerotic plaque, or that atheroma, it becomes very very thin, and the plaque becomes unstable. Unstable means it's going to rupture. So that is what has caused us this, unstable angina in our patient. So unstable angina now is related to, you see, I've highlighted this word. Shall we learn this? Thrombosis. Okay. So this is thrombosis with incomplete coronary occlusion. Now, very important. You need to again imagine this. Plaque has ruptured. So does that suddenly lead to full thrombosis and blocks the blood vessel? No, it takes time for this thrombus to build up. Okay, so this is a clot that is forming on top of that ruptured area, right? So it takes time. It might take a few days even to build that clot slowly. Okay, so as the clot is building up, the clot is increasing in size. Okay, so imagine what is happening. The plaque has ruptured in a blood vessel. Clot is building up, slowly building up. So is that progressively reducing the vessel lumen? Is that progressively reducing the amount of blood that would flow into the heart muscle? Yes, right? Agreed? So as the thrombus is growing, less blood is, going to the heart muscle. So if progressively less blood is flowing to the heart muscle, will that cause progressive increase of pain? Yes. So I told you, you know, pain is directly sort of a sign of, less blood going into any muscle in the body, actually, right? Pain, in this case, we talk about heart muscle. So this type of pain, how would the patient describe it? What would the type of pain be? Progressively increasing, so increasing frequency. And we use a word, so and it's a word used in music education also. When we talk about music, increasing frequency music or increasing intensity of music is called as a crescendo, right? We use that word in medicine a lot. So it's crescendo, which means the intensity of sound is increasing. In this case, the intensity of pain is increasing because of that thrombus is growing. As it is growing, less and less blood is flowing to the heart muscle. Okay. So in this case, chest pain may also occur at rest. And why do I say this person needs urgent medical attention now? Because again, very important concept. Is this MI? Is unstable angina MI? We are still on angina topic, but this is not MI. Okay. But can unstable angina, is it going to lead to MI eventually? Answer is yes. But when? The answer to this when is when this clot that is increasing, when this thrombus that is growing, eventually in 1 or 2 days, or in like maybe one day, let's say one day, once it fully blocks the blood vessel, okay, keep that in mind. MI happens 30 minutes after complete blockage. 30 minutes after complete blockage. If you want a range, that is 20 to 40 minutes after complete thrombosis, 100% blockage. Unstable angina is not 100% blockage, but is it going to lead to that 100% blockage? Yes, eventually it will, right? So if this patient comes to you, why is this, a very urgent attention patient, a critical care patient? Why? What is the reason? Because you want to prevent MI. Simple reason. Can we prevent any necrosis from happening in this stage? Of course, if you identify this, if the patient is in your clinic, you would not let the patient go back home, right? You can prevent this complete blockage and you can prevent any necrosis that would have happened. Okay. So recognizing this is important. Okay.